new section starting with acute leukemia up and through Monday's solid organ transplant. There's about 10 questions, just like there have been formatted on all the other exams. And then there is a larger cumulative component compared to previous exams. So on your first couple of exams, you only had a couple, like 2 or 3 maybe questions from previous content. It's upwards of more like 20, 25. I haven't received all of them yet, so I don't know the total number. It's still getting them for people. But it's going to be at least 20 cumulative questions, which is a difference from your other exams. So I wanted to make sure I told you that. The majority of the cumulative, I'm giving you a hint because I'm nice, is from the last 2 exam sessions. So there was a section you felt particularly difficult for yourself, you may want to review that. The cumulative are mostly non-case based, so like the previous cumulative questions, it's a direct, either you know the factual information or you don't. Drug information, key facts about disease states, those similar things. There are a few simple case-based that I've received, so I did want to tell you that because that's a little bit different than the other cumulative questions. But the vast majority of cumulative are going to be from the last 2 exam sessions. But there are more cumulative than there have been on the other sessions because this is a longer final. And you do have 3 hours, not 2 for this exam, so don't be stressed about the time, please.
Dr. Clemens, can you tell us how many drop quizzes there are going to be?
I think it's 2, but honestly, I have to consult what we wrote the syllabus last fall because we did that so long ago. I believe it's 2, but if it's not, I will post to ELC what it is. I hate to just misspeak because we make those decisions way in advance and then it slips out my brain. So if it's not 2, I will let you know via ELC. And whatever it is, it's going to be automatic in the grade book. The IT folks were great and they helped me set that up in advance. So hopefully, after next week, it should automatically show you all that because they programmed that in. But that was done so long ago. Honestly, I forgot about it. Other questions? Okay, so we're going to dive into the transplant talk. Obviously, this is my personal favorite because this is my particular practice site. I do think that it's important to have a general understanding of transplantation, regardless of your practice setting, as the number of patients going through these processes and the length of time in which they are surviving afterwards and needing follow-up supportive care and on other medications out in the community setting is increasing. As I mentioned in several lectures, cellular therapy is advancing rapidly in the next 3, 5, 10 years. I expect to do this lecture completely different and not be about stem cell transplant, but be about cellular therapy, because that field is rapidly changing. But we'll just dive right into case number 1 to start. So BB is a 58-year-old African-American male who has multiple myeloma, hypertension, hyperlipidemia. He's already received bortezomib, doxorubicin, and dexamethasone, as well as lenalidomide and dexamethasone, which are some standard regimens to treat myeloma. He is in remission. He has insurance with transplant benefits. He lives at home with his wife. I provided some labs for you, as well as his medication list. So thinking about this type of patient, group number 7, what type of transplant is this patient eligible for and why? Okay, so the rationale for an allo transplant is to do what?
Used as an outside source of stem cells?
Sorry, that's really muffled. I don't think we can, at least in Augusta, we can't hear that.
Used as an outside source for stem cells?
Right, so it's either replacing a dysfunctional marrow, so if you have a disease like aplastic anemia, for example, you can replace it with a functioning marrow. Is that true of multiple myeloma? No. And then what's the other rationale for allogeneic transplant? The cells themselves are doing what? You can phone a friend here, anybody. What are the cells from an allogeneic donor doing?
Finding the cancer cells.
Right, so your graft versus malignancy or GVL, graft versus leukemia effect. But that only is true of certain diseases. So this is really important to kind of think about. So an allogeneic transplant has one of 2 indications. For malignant conditions like leukemias, it is providing a graft that's going to identify the host disease as foreign and fight it off. Your immune system, that's what it does, right? It looks at things, says, are you me or not me? Self or non-self. If you're non-self, like a virus or a bacteria, it kills it off, right? So it can identify cancer cells because they're mutated and have different expression and markers as foreign and kill them off. So if you give somebody else's immune system to a patient with a leukemia, it should identify those leukemia cells as foreign and bad and kill them off. That's what we want to have happen. That doesn't always happen with every disease state. Some disease states, that doesn't work. The cancer cells don't look foreign enough, so they aren't fought off. So there's only certain diseases where that is applicable. I don't expect you to know which of those there are. In some diseases, it's controversial as to whether it exists or not. But that does not exist in multiple myeloma. And then for non-malignant conditions, the use of allogeneic donor stem cells is replacing and correcting a deficiency or disorder. So you have aplastic anemia, beta thalassemia, some sort of inborn error of metabolism type pediatric condition that I don't know really anything about because I have to do peds transplant. So there's a very long list of very rare congenital conditions that can be corrected by replacing their bone marrow. And those are non-malignant conditions. In that case, there is no GBL because there's no L, right? There's no cancer, there's no leukemia. But you're replacing something. You're getting rid of a dysfunctional and just putting in a newly functional. So you don't need GBL and you don't want GVHD. So in the case of diseases that don't have immunodeficiency disorders, they're not non-malignant conditions. And in the case of areas where there is no graft versus malignancy effect, there's no point in giving donor stem cells because they're not doing anything different, right? They're not helping you at all. So what's the point of an auto transplant? Anybody? What are the cells doing there? They're not fighting disease. Why do we care? Why do we need them?
Is it to help mitigate the dose-limiting toxicity expression?
Yes, it is. So for an auto transplant, auto means cells. You're giving their own cells back. The only reason we're collecting cells and saving them in the lab is so they're protected from the high doses of chemotherapy. Because more and more chemo sometimes can be better at killing cancer, but eventually you're going to kill the patient. So you have to be very careful. And most of the doses that we give, the limiting toxicity is myelosuppression. You can overcome myelosuppression by giving stem cells back. You take them out of the body, you protect them from the chemo, you give them the chemo, and then you give their cells back. And then those cells can regenerate and go back to normal functioning bone marrow. So the whole point of an auto transplant is to protect their bone marrow from myelosuppression by exogenously removing them and putting them back. Yes, ma'am.
I actually have 2 questions, I'm sorry. If this patient has their CV status in normal limits, why do we need to rescue them?
So it's in normal limits before the transplant, right? So when this patient's going to come in, and I'll just tell you, they're going to get melphalan chemotherapy of a high dose. So they come in with normal counts, you give them melphalan, and then over the next week to 2 weeks, their counts go down. They would take weeks to come back up, and potentially the patient could pass away in that period from infections or bleeding or other complications. But you give them the chemo, and then you give them their stem cells back. And we give them on day 0, which for this regimen is the day after chemo. It just happens to be that way. It takes days for those stem cells, when you infuse them into the peripheral blood, they don't just automatically attach to the bone marrow and start chugging out new cells. That process takes time. It takes several days for them to come home to the bone marrow, attach to the bone marrow matrix, and start making cells. And remember, all the way back to your pathophys, from a stem cell to a red blood cell, a stem cell to a platelet takes time. And so usually it takes about 2 to 4 weeks, depending on the type of transplant, for those counts to come back. For an auto, it's faster, because of your own cells, you don't have any of that crazy, mismatch going on. So that takes about a little less than 2 weeks. Our average time to engraftment at our hospital is 11 days for an auto. Students always come on my rotation and they're like, how do you know that they're going to engraft next day? I'm like, sounds like magic. I'm like, oh, their counts are coming back tomorrow, and they do, because it's always there. That's just our institutional average, and so I can predict it. It makes me sound really smart, but really, it's how it always goes. So yes, you may come in with transplant with normal counts, but as soon as I give you that high dose chemo, they're going to tank, and they're going to tank over the next 5 to 7 days. But giving those stem cells allows you to engraft faster than if I didn't. We figured out a long time ago, we being obviously not me, that people would die if you didn't give more and more chemo if you don't give them the support of the stem cells. So all an auto transplant is doing is helping them recover from the high dose chemo faster and safer. There's no magic to the stem cells. They're physically doing nothing else in the body except giving the patient their blood counts back. And allo, most of the time, is doing something else. It's fighting the cancer. We want that graft versus malignancy effect. That's the benefit to it, and that's the cellular therapy part. And so which diseases get which ones, I had a slide that I listed for you. That's not testable information. I don't think that's necessary. I would just tell you what transplant they're getting in the case, and you can assume that it's correct. But what I may ask you is what's the rationale for a transplant? Because patients need to understand this. They need to know what the point is and what the risks are. Because if you're getting an allo transplant, your risk for GVHD. They need to know that and what that is. Versus if it's an auto, they need to understand what myelosuppression is and what side effects they may have. So I think it's important just to know the rationale because that tells you what kind of toxicities and side effects they're getting. And it also tells you a little bit about their transplant-related mortality. It's very rare to die from an auto transplant. It's not that complicated of a procedure. There aren't that many risks. Versus an allo transplant, depending on the type and other things, up to a third of patients can die in the first 30 to 100 days after transplant. So that's a much riskier procedure. So when you consent and talk to a patient and a physician that is, they need to really understand this. And sometimes I come in and do the transplant education, it's like they've never heard it before. We really need to make sure they're well educated and understand what's going on and what they should expect, so that they can make an informed decision about their treatment regimen. So for this patient, they're going to receive an auto transplant. And it's because myeloma was on the list of things that don't have GVO in the pre-class slide. Again, I'm not going to test you on that, but I more wanted to have a good discussion about the rationale for each type because that's what's more important. Okay, so group 7, keeping on with this patient, we need to mobilize the stem cells to collect them for the auto transplant. What are our options for mobilizing stem cells for an auto transplant patient?
Just monotherapy with the growth factor.
Okay, so I heard growth factor and then the rest of it was a little muffled. So if you said anything beyond that, we didn't catch it. Someone else in your group might need to use a different mic. I'm not sure if it's just a connection issue.
Just growth factor monotherapy.
Okay, so that's definitely one option, is just growth factor by itself. For auto patients, there are 2 other options. What are they? Anybody?
Growth factor plus Plerixafor and chemotherapy plus growth factor plus or minus Plerixafor.
Good. So for an auto transplant patient, you can use growth factor to literally mobilize those CD34, which are your stem cells that are normally attached in the bone marrow. We can break those attachments and get them to be floating around in the bloodstream, and then we can collect them peripherally. So growth factor is going to increase the number of your stem cells and help get it out into the peripheral blood. Plerixafor is another drug that has a specific mechanism to break the connection of the CD34 cells from the bone marrow matrix, so it can really help release more cells. We usually use that on an on-demand basis. Every hospital has their own protocol, but for cost-saving reasons, because it's an expensive drug, we try to only use it in people who aren't doing well with just GCSF or filgrastim or Neupogen or any other name you want to call it alone. And then the chemotherapy with growth factor, with or without Plerixafor added on, is typically reserved for patients who aren't mobilizing well off the previous regimen, because obviously chemotherapy comes with higher risks and side effects, so we try not to do that if we don't have to. But we will do it in patients who are only in a partial response, not a complete response, to get a clean marrow graft by mobilizing off chemotherapy. So which of these would you never use in a healthy donor for an allogeneic patient?
Yep, that's it.
So if I'm donating to my sister who has leukemia, what would they never give me? Somebody here knows for the last 2 options, and that's correct. Right now, Plerixafor is not FDA indicated for healthy donors. I won't test you on this, but there are studies ongoing, and I believe that's going to change. The safety is being evaluated, and the efficacy is already somewhat proven. So that may change. So right now, we're going to go with can't use it because it's not approved, but it probably is going to be different in a few years. And then chemomobilization, obviously would not use in a healthy donor. That would make no sense at all, right? You don't give people chemo who don't need it. So right now, the only choice for a healthy donor donating to a sick patient is the G-CSF or filgrastim by itself. But for an auto, you can use any of these three. Now, for an auto patient, which of the three would you pick? I also would never test you on that because that would not be fair. There are a lot of patient-specific discussions that happen with that, but I did want you to just be aware that there are a couple of options to do so. And remember that the collection process starts before the transplant for an auto. You have to collect the cells, freeze them, and then bring them in for their chemo and their transplant. So the last question is, what are the two ways to actually physically get CD34 stem cells? How do we obtain them? Anybody? Good. So the leukapheresis is the process I was talking about where we can get them into the bloodstream and they basically go and can fit on a machine that looks a lot like a dialysis machine. It filters their blood, takes out the CD34 cells and puts everything else back. Now it's not 100% perfect. There is some red blood cells and other cells in that product, but the vast majority of what's in the bag is going to be CD34 cells. And then it just gets reinfused on day 0 of the transplant like a regular blood transfusion. It's fairly anticlimactic. And then the other way is a bone marrow harvest where you actually use needles, typically in the iliac crest. You can get it from other bones in the body. And you suck out bone marrow, and then that can be reinfused into the patient through their peripheral blood access. Now, for autos, it's almost exclusively leukapheresis. I've never had an auto patient undergo bone marrow harvest. I guess technically you could do it, but why would you? It's not necessary. For allo patients, we'll talk about in a little bit the difference between the cells for risks. And so for an allo donor, they could undergo either of these procedures, depending on what we're trying to achieve in the patient and what risks we're trying to mitigate overall. But either one can be used for healthy allo donors. Any questions about mobilization? So for an auto, you have 3 options. For an allo, you only have 1. You always want at least 2 million cells for a transplant. And for an auto, you do apheresis. And for an allo, you can either do a direct bone marrow harvest in the OR, or you can do the leukapheresis procedure. Okay. So case number 2, group 18, we're going to start with you all. AJ is a 42-year-old male of Asian and African American descent, and he presents for an opinion at our cancer clinic for a bone marrow transplant. He's obese, has hypertension, and he has high-risk AML. He received that 7+3 induction, got into a complete remission. He got 1 cycle of HiDAC. He relapsed, unfortunately, and had to be reinduced with a regimen called MET. That's not that important in this case, but this is a real patient, so I'm putting it in here. And then he's in a 2nd complete remission at this time. He has a normal echo. His LFTs are fairly normal or a little high. T-Body is 1.6. His chemistries are normal, and his pulmonary function tests are normal. So what type of transplant and what type of conditioning would this patient be eligible for?
An allo transplant, and he needs myelosuppressive and immunosuppressive conditioning.
Great. So because he's acute leukemia, if you go back to that pre-class slide, he does need the allo transplant to help with the graft versus leukemia effect. He's also high risk AML, and we talked in our AML section that high and most intermediate risk as well, once they are in a remission, should go on to an allo transplant for the best long-term outcomes. And I agree, he would need myelosuppressive and immunosuppressive therapy because he's receiving donor stem cells, so immunosuppressive agents are necessary. Now, he also needs myeloablative chemotherapy, not reduced intensity. And the reason for that is really he's young and he's physically fit. And so he could receive that. So we wouldn't necessarily need the non-myeloablative or reduced intensity because he's not old, he doesn't have significant comorbidities that we think are going to make him not be able to tolerate it. And his labs look pretty good. I mean, he does have a little bit of LFT elevation, but that's something we can monitor and isn't necessarily an exclusion. So his cardiac and pulmonary functions are normal, so we want to give him the best chance with a myeloablative regimen. So the same group talking about, just to reinforce what we talked about before, what's the rationale for giving this patient allogeneic donor stem cells?
They can help fight his cancer cells and then also replace his marrow that we are gonna ablate.
Good, so that graft versus malignancy, graft versus leukemia effect is the main goal, and then replacing that dysfunctional and potentially cancerous, again, bone marrow is part of the reason. Now, because we're using myeloablative, part of the myeloablative regimen is also going to kill off any residual cancer cells, because more chemo can kill off more cancer, so that can be helpful. And we know that some cancers have very steep dose response curves, so more chemo can be better, but again, then you have to rescue them with some sort of stem cell support. But the reinfusion of those cells is not only overcoming that myelosuppressive effect, but also providing that graft versus leukemia effect. Good. So group 26, so this patient agrees he wants to go on to an allotransplant. There are 3 different sources for CD34 cells. What are they? And then for each one, talking about like their pros and cons.
Okay, so one option is cord blood, and this one is the longest time to engraftment. It has the lowest GVHD risk, but it can cause infection. The second is the bone marrow, and it's kind of in the middle of time to engraftment, but it can cause post-op pain. And the last option is peripheral blood, and this is the shortest time to engraftment, but it can cause T-cell contamination.
Excellent. So cord blood, as you pointed out, has some pros and cons. So it's a limited number of cells because you only have the blood that's in the cord. That's it. You can't go back and get more from the mom or the baby. Like, it is what it is. And so that can be a limitation in adult transplant, because if you remember back, I said we need at least 2 million cells per kilogram of the recipient. So pediatric patients obviously weigh less than adult patients. And some adult patients weigh a lot more than others. So for some adults that are small, you can get away with a cord transplant because you can get enough. But for older or for larger or obese adults, it's really hard to find cords because you don't have enough cells to actually safely do the transplant. Now, I won't test you on this, but I want you to be aware, we actually do double cords. We take 2 cords from 2 different babies and combine them and give them to a patient. And it's fascinating to me because in the interim, those patients, adult patients, can do better than someone who got a single cord. But long term, only 1 cord actually engrafts. So 1 cord is just supports the other, and nobody ever knows which one's going to end up being their new immune system. So it's kind of interesting how that interplay happens, but we are limited in the number of cells. And so that's one major problem. The other major problem, as you pointed out, is that these are naive, literally baby blood. They've been exposed to nothing else. They have no immunity. So they have no antibodies to anything. They have never been exposed to anything. So the infection risk is definitely higher, because you have none of those mature T or B cells that are contaminated in the graft, which could help you, right? That would be maybe a good thing for immunity. And so these patients have a lot of infections with viruses, bacteria, and fungal as well. But it's baby blood, so that's one limitation. The pro to that is because it's never been exposed to anything and has no immunogenicity, it's less likely to cause GVHD. So those patients have lower GVHD risk, but a lot higher infection risk. So it's a balance out, the risk to benefit there. And as you pointed out, bone marrow is kind of in the middle with time to engraftment. And the problem most people discuss with bone marrow is you have to have a donor who's willing to do this procedure. It is extremely low risk for major complications, but patients do have several days of post-op pain. And they do require some temporary, typically narcotic use for that. So you just have to have someone who's willing to undergo anesthesia and have the kind of week or so of post-op pain, which sometimes can be a limitation. Some donors don't want to do that. But overall, bone marrow has definitely a lower GVHD risk than peripheral blood. So in the case of allogeneic transplants where there is no GVL, you don't want to risk having any GVHD because there's no benefit to it, right? It's not doing anything beneficial. So in those cases, they use bone marrow grafts. So for a lot of the pediatric transplants that are for those congenital disorders, there is no GVL, there's no L, there's no leukemia, there's no malignancy. So in those cases, they do want the donors to use bone marrow source because they want less GVHD. So if there's no GVL, there's no point in having GVHD. And for pediatrics that live long time after their transplant, chronic GVHD would have a significant morbidity burden on their quality of life. So pediatrics, they're very adamant about trying to reduce GVHD because the long term, if they survive, if they have chronic GVHD that's impacting all these organs and has a lot of morbidity, that can be very difficult for patients to live the rest of their life with. So if you don't have GVL, if you don't want GVHD, you probably want a bone marrow graft. And then peripheral blood in the adult setting is the most common because our patients, our healthy donors are willing to do it that way. And it does have the fastest engraftment time. And that's beneficial because the faster you engraft, the lower number of days you're at risk of febrile neutropenia. And also the lower number of days you need transfusions of red blood cells and platelets. So there is some benefits to the patient as well as financial benefits to institutions of getting people out of the hospital faster, having fewer transfusions. And it's also obviously easier to obtain those cells. You send the patient to apheresis, they have a machine over a few hours, they collect the cells, they get to go home. So there isn't any anesthesia, there isn't any pain, so it's a little bit easier. But as you pointed out, it's a peripheral graft, so you are going to get some contamination of other cells, and that means you have more T cells. And as we talked about the pathophysiology of GVHD in the pre-class lecture, T cells are the main implicating factor that starts that process. So donor T cells are implicated in the pathophysiology of GVHD, so more of those does technically put you at higher risk of GVHD. Now, if you need a little bit of GVL, you'll buy a little bit of GVHD. You're okay with that to get the GVL. But again, if you don't need any GVL, no point in having GVHD. We would not want necessarily to use a peripheral source if we didn't have to. So who gets which one? We only use cord if we have to. That's not standard of care first line. So if you can't have a related or unrelated donor because you don't have any matches, then we would go on to cord. So that's not first line. It would only be if you needed to do that. But between peripheral and bone marrow, it really hinges on do you need GVHD or not, and is there any benefit to that, and that helps us make the decision. I wouldn't on an exam make you necessarily pick, but I want you to know the pros and cons and risks and benefit of each one, again, because that's what we counsel patients on, so they know what the risks are. Any questions? This all came directly off this pre-class slide if you're wondering where that came from. So cord blood does provide a little bit of graft versus tumor effect, but it's not considered necessarily as much as you would get with peripheral blood from a related or unrelated donor. Cord blood is still considered one of our alternative sources, along with haploidentical. And those two, there's ongoing studies about which one. There's actually an ongoing study comparing them head-to-head, haplo and cord. We don't know which one would be better, but there aren't any studies comparing them to match-related or match-unrelated, because right now those are standards and people are getting that. Wouldn't necessarily be ethical to randomize patients to something that may not be as good. So that's a hard question to answer because we don't really have the data. It does have some, effect, but not as much because it is fairly naive. So that also can be a limitation to it. We don't use it as much in adults as they do in pediatrics, but again, there's a lot more pediatric conditions that are, inborn errors and immunodeficiencies where you don't even need the GVL or GVHD, so they're using cord and they don't even have to think to worry about it, because they're treating a different type of non-malignant condition. Other questions? Okay, group 12. We're going to talk a little bit more about matching now. So this patient has several siblings. One is a 0 out of 6, one is a 4 out of 6, it's considered a preserved haplotype, and one is a 6 out of 6. So what does this 6 out of 6 mean? And then we're going to talk about what is a haplo.
Dr. Clemens,
Go ahead.
there's a lot of feedback on your mic. Is there any way that you could do something to fix that?
We only have this one mic. I can hold it like this. I think somebody elsewhere has their mic on because we have some staticky feedback in the background as well. I don't think it's my mic. I think someone else's. There it is. Yay.
That was Savannah, sorry.
That's okay. No problem. Thank you for saying something. Okay. So do I need to repeat the question? I want to make sure y'all heard me.
Yeah, would you mind repeating that?
Yeah, no problem. So I was asking group 12 about part 4 of this case. So this patient has a couple of siblings. So one is reported to be a 0 out of 6 HLA, one is a 4 out of 6 that they're calling a preserved haplotype, and one is a 6 out of 6. So kind of explain to your classmates what 6 out of 6 means, and then we're going to talk about what is a haplo, what does that mean, and how do you obtain one.
Okay, I think the 6 out of 6 is the minimum required to do a transplant with them, is that correct?
That is, so for when we're talking about sibling transplants or related now, unrelated, and those two types of transplants, you have to have at least a 6 out of 6. I don't think I included it in the pre-class because I didn't want to confuse people. Technically, you only need a 4 out of 6 for a cord, and for a double cord, they don't have to match each other the same way they match the patient. It's all very confusing, and we don't need to get into that, but it is more complicated, and thankfully we have people down in the HLA lab that do all of this for the transplant team, and they just tell us what the best thing is, and we go with it. So we do rely on our lab fellows to help us with this, but I feel like it's good to kind of know the terminology and understand what they're saying. I'm not going to get super nitpicky about any of this on the exam, because that's really beyond the scope of the pharmacist, but having a basic understanding so when they're talking, it's not like, phew, way over your head. So a 6 out of 6 for a related or an unrelated transplant is the minimum. So when we say 6 out of 6, 6 what of what? What does that mean? What are we referencing?
It's the different HLA markers, there's like A, B, C, whatever the other ones stand for.
Yeah, so the 6 are which ones?
A, B, C, and then I think there's 3 D ones, but I'm not sure off the top of my head which ones those are exactly.
Right, so there's A, B, C, DR, DP, and DQ. But 6 out of 6 actually isn't all 6 of those, right? Because you get 1 set from your mom and 1 set from your dad. So you are going to inherit something from each parent to make your own human leukocyte antigen markers, right? So a 6 out of 6 is actually A from your mom and dad, B from your mom and dad, and DR from your mom and dad. So it's 2 A's, 2 B's, and 2 DR's. That makes your 6. And that's why I point this out, is because there are 6 different things you can match. But technically, if you matched all of those, that's a 12 out of 12, right? Because you have to match both sides. So this person right here, if we had another sibling or an unrelated who had this exact same set of 6 things, they would be at a 6 out of 6 match. And I think I show that a little bit differently here. So like here's your patient who has these, and these are just color-coded rather than numbers, just for visual appeal, who inherited this haplotype from this parent and this haplotype from this parent. So their sibling C isn't a match at all, but their sibling A is, right? This haplotype plus. Does that make sense? So 6 out of 6 doesn't mean A, B, C, DR, DP, and DQ all matched. It means A, B, and DR matched both sides. Bless you. Again, I just want you to kind of have a general understanding of what they're doing. This is not like high priority testable information, but I feel like it's important to know when they talk about matching and mismatching what they're talking about. So a 12 out of 12 would be ideal. And the reason we only go for a 6 out of 6, like that's the minimum, is A, B, and DR have data showing that they correlate with mortality and graft versus host disease and those sorts of outcomes, versus things like DP and DQ. There's conflicting data as to whether matching them really impacts overall survival or not. So you don't have to match them. It's nice to, but it's not necessary for their long-term clinical outcomes. And again, this is just what we know about HLA so far. Things can change as we research more on what matches are beneficial and with different types of transplants and donors, what's necessary. I just wanted to give a general lay of the land of what is HLA and why do we care. So on your leukocytes, which are your white cells, there are cell surface markers. And again, your immune system and someone else's immune system are going to look at each other and say, are you me or not me? So if you don't express the same markers, you might not be me, and I'm going to get the rest of the immune system to fight you off. That's how graft versus host disease works. The immune cells look at each other and say, are you self or non-self? And things that are non-self, the immune system is going to fight off. Unfortunately, the rest of your body also expresses some markers of self and non-self, so if those conflict, other organs can be attacked, and that's that graft versus host disease. But you also, you need to make sure you don't reject the graft, and that's what the immunosuppression is there for, to kind of calm down the immune system so you don't fight it off, the new graft that we're putting in. So matching is really important to prevent graft versus host disease and prevent rejection, but you don't have to match everything. You can get away with the 6 out of 6 and still be predicted to have good long-term outcomes. So that is an acceptable thing. And like we talked about, the half low is just a half match, but it's a preserved amount from a parent, right? So siblings don't necessarily match each other. Mendelian genetics are going to show you only got about a 25% chance of matching your sibling, right? So just because you have siblings doesn't mean you're going to have 6 out of 6, 12 out of 12, whatever. They may not match, and that's when we go to that unrelated donor pool. So we always check siblings first, and if they match, that's great. That would be the easiest thing, because usually siblings are willing to donate for their family member, typically, not always. And then we go to the unrelated pool, and that's the donor registry, and we try to look for an unrelated donor. Unfortunately, patients who come from a mixed background are less likely to have a match, because again, the people in the registry have to have the same type of genetic background, and that is racial and ethnic related. And so we are, as a transplant community, trying to increase and encourage more bone marrow drive, especially in communities that are non-Caucasian predominant, to increase the likelihood that a patient of a different background would be able to have a match. And so if you're not in the National Marrow Donor Program, be the match. If you haven't ever been swabbed and in there, I definitely highly encourage you to do so. That doesn't necessarily mean you'll be called as a match, but if you are, you really could help a patient out there who is looking for a donor if they don't have any family members that match, or their family members are too sick or something to be able to donate their cells. So that's my little public service announcement for philanthropy for today. So I kind of went off on a small tangent and gave Group 12 the answer to Part C a little bit. So the other option, if your siblings were unfit, where would we go? Well, I just said one thing, right? So the unrelated donor registry. We have one. The one in America is NMDP Be the Match, so National Marrow Donor Program. There are international registries as well, and from different countries. So Italy, France, Brazil are 3 other countries that have very large programs that publish a lot of data, and we've gotten cells from. I've had patients here in Augusta get cells from Poland, Germany, different countries in South America. So we do, if we exhaust our options in the United States, we can look at international registries and get things shipped from afar. So that is a possibility to get an international donor. There's some more timing logistics that have to play into that with, again, the flights and time changes and things. But that is a possibility. So unrelated donor searches first, because there's a lot more data with this, and we know we can match them pretty well if we look in the registry. So what's the other option we talked about earlier that is an alternative if you don't have a family member or a registry match? What's that last option that we talked about? Anyone?
That was the cord donation, right?
Yep, cord. So women who are pregnant, if they deliver their baby in a hospital who does banking, not all hospitals do for whatever reason, you can donate the cord blood to the bank. So it's just like we have an unrelated registry, there's a cord blood bank that actually freezes and keeps these cords. And so that's something that you can be screened to see if any of those cords match as well. Typically when we do the screening, just so you're aware, there's like high resolution and low resolution. So they'll do a high resolution to say, do you meet the A, B, and DR, basic antigen, yes or no? And if yes, then they can run an additional screening to look if the alleles also match, and if the C, DP, and DQ also match. Because if at a basic screening you don't meet the 6 out of 6, there's no point in looking further, but if you do, we can see if, maybe you're 10 out of 10 or 12 out of 12. So there are different levels of screening in which they will do. This takes time. It's not like you can just punch in a patient's genetics and look in a database that's easy. You send the patient's information to either the unrelated registry nationally, internationally, or the cord registry, and then those people will look in their registry and either run the high resolution if they need to, or tell you there were no matches on the low resolution. And that can take a few weeks, so this isn't a very quick turnaround. And the reason I'm pointing this out is we skipped it in class, but I talked about it in the pre-class session as to the timeline of a transplant. Remembering that this process for an allo can take quite a bit of time. We have a patient who gets diagnosed with a cancer that may be transplant eligible. We have to get them in a remission first. While we're doing that, we're working them up for the transplant in case they get into a remission. Because if you wait till they're in remission and start the transplant workup, they could relapse in the amount of time it takes you to find and get a donor. And sometimes you find a donor and they reach out to the donor, they can't find the donor anymore. The donor just got hit by a bus. The donor got pregnant. The donor now got diagnosed with their own cancer. I mean, things happen. So that doesn't necessarily just because you find a donor mean they're going to be able to, or the timing doesn't work out. They're not able to take off work and do the procedure, or something else has happened. They've changed their mind. So we do start the workup looking for donors right away for these patients because of the amount of time it takes. And that's really important for some patients who are barely in a remission or are expected to relapse very quickly based on the risk of their disease and the bad side of genetics and things like that. And so we try to get the ball rolling as soon as possible. So while I'm treating leukemia patients, we're also discussing their transplant plan all along. Sometimes, unfortunately, that's wasted effort because they don't get into remission or they die from induction or something else bad happens. But we have to do it in tandem or you'll miss the boat and you won't be able to get them to the transplant at all. So to me, that's one of the interesting things about treating these patients is you get to do multiple things all at once. And so the care of the patient is multifactorial and more interesting. So that's kind of happening all at the same time. Once you find a donor, remember that they are going to be undergoing that procedure with their growth factor and their collection at the same time the patient's undergoing the conditioning chemotherapy. The reason for that is it would be unethical to put that healthy donor through this process in advance of the patient coming for transplant. Because what if the patient relapses, has a major complication, or dies? You just put a healthy person through these risks for no benefit. So ethically speaking, donors are done in tandem with the patient. Now, family, sibling related donors, sometimes they'll consent and they'll do it ahead of time, like right before. That has happened, but unrelated donors, the registries won't let you do that. You cannot mobilize and collect a healthy donor unless your patient's actively undergoing the transplant. Question comes up, what if something happens to one of the other person? Well, that's a risk we take. I've had a donor start and the patient had a problem, and I've also had the patient start and the donor come back positive with a pregnancy test. So those are problems that cause the transplant to stop. Thankfully in my situations that happened on the first day, so we were able to stop and not have significant untoward effects. But because they happen in tandem, there is a risk here for either the donor or the patient to receive things that they don't need and have problems from it. But I want you to be aware of the timeline of how this works just in general. So question about donor options, matching, timeline. So if a patient started conditioning and for some reason died before they got their stem cells, what would we do with the donor cells? I actually don't know the answer to that. I think they would be discarded because there wouldn't be a way for like the local institution that collected them to then be able to give them to another institution later on. Like there wouldn't be any coordination for that because the registries are registries of screenings, right? They don't have stem cells from all the people that are willing to donate. They just have the screening and then they reach back out to the person if they're gonna collect. But the only thing is a cord blood bank obviously physically has the cells, but there's no physical bank for collected cells from donors outside of the cord. So like who would keep them and how would they liaise and give them to someone else? Like I don't know the logistics of that. I would assume they would just be discarded. That would be extremely rare to have happen. I mean, in the 9 years I've been doing this, I've only had 2 cases. Again, the one where the donor came back positive the first day and we had to stop, and the one where a patient came in, started chemo, and then things kind of went downhill and they decided to stop, so we stopped the donor. I believe that was a sibling actually, so that wasn't as big of a deal. But this kind of thing doesn't happen that often, but there are things to just think about of implications of how we do things and how to mitigate any complications or problems. Okay. So moving on. on to the next part of this case. So our same patient comes to the hospital to receive chemo conditioning. I would not have you choose a conditioning regimen for a patient. That would not be a fair thing. But this patient is going to receive the myeloablative busulfan cyclophosphamide regimen. He's going to receive a transplant from that 6 out of 6 match-related sibling that we talked about earlier, who would be the best match, obviously. So let's do group 23. What are these chemo agents? Are they myelosuppressive, immunosuppressive? And then what are their dose-limiting toxicities?
So the cyclophosphamide is immunosuppressive, and the busulfan would be myelosuppressive. And then for cyclophosphamide, the dose-limiting toxicity is cardiotoxicity, and for busulfan, it's hepatic and pulmonary issues.
Great. So the dose-limiting toxicities, as you'll notice, they're not myelosuppression anymore. We've exceeded that. Now we're on to other organ toxicities. And this is really important from a counseling perspective, as well as a screening of patients. If this patient had poor cardiac function coming in, he probably wouldn't be eligible for Buci because he can't get the cyclophosphamide. He would be too high of a risk. For patients who already have pulmonary complications or low PFTs might not be able to get busulfan. So knowing the dose-limiting toxicities is important for eligibility of transplant as well as counseling points. So this slide is testable information. Knowing that total body irradiation, fludarabine, and cyclophosphamide also have immunosuppressive properties is important because we don't use those in an auto transplant. You don't need immunosuppression. You're giving their own cells back. There's no mismatch. There's no issue. So you don't need that. Versus an allo, maybe you need the immunosuppression to quiet down the GVHD risk, right? So this slide I would star for your reference. Same group, other counseling points for these agents, kind of thinking back to previous lectures, things we've talked about, and then refresher on some of that.
Depending on the dose of cyclophosphamide, they might have a higher risk for experiencing nausea and vomiting.
True, so it's going to be high dose because in these conditioning regimens, it's always high dose. And we're trying to get the extra cancer killing effect as well as ablating the marrow, wiping it out completely. So you definitely have high risk of nausea, vomiting. What else from cyclophosphamide, and then what else from busulfan?
Hemorrhagic cystitis with cyclophosphamide.
Long term, there are 2 risks with cyclophosphamide. Patients would definitely want to be aware of. All that from intro lecture.
Infertility and then a risk of like secondary.
Right, so cyclophosphamide does cause infertility, and most people by the time they get to transplant have had enough chemo that this has been addressed, so we usually don't need to rehash it for them. They're already aware, but I still make sure they're aware of it. And then the secondary malignancies is an important comment that they need to know of. And then for your busulfan, anything specific you would want to monitor for, counsel the patient on, be aware of? Anyone?
Neurotoxicity.
Yeah, so neurotoxicity and seizures can occur. Patients that get busulfan for transplant actually receive seizure prophylaxis for about a week. They don't have to continue it lifelong, but during the busulfan and a few days after, they actually do get prophylaxis. And then, what was the other thing you said? Hepatotoxicity, yes, thank you. I heard it. And so that is a dose-limiting toxicity, and getting busulfan puts you at risk of what post-transplant complication related to hepatotoxicity. What is that called? A couple people heard Augusta said VOD, which is now termed sinusoidal obstructive syndrome. It's the same thing, and we'll see that in a few cases, but that is definitely an important consideration for people that have had hepatic problems in the past, have baseline issues coming into transplant. They may not be eligible to get the busulfan because of the high risk of VOD after the fact. Good. So moving on, group number 1. So the patient receives the Buci regimen. What are some other pre-engraftment phase related complications to be aware of.
You could get VOD.
Yeah, so that VOD definitely is a risk in the first 30 days. Typically, it can happen after that, but the vast majority of cases are going to happen in the first 30 days in the pre-engraftment phase. What else?
You could get a viral or fungal infection.
Good. Which virus and which fungus are we most concerned about in the pre-engraftment phase?
HSV virus and Candida and Aspergillus fungus.
Good. So definitely Candida over Aspergillus. You can get Aspergillus, but it's not as common in the pre-engraftment as it is a little bit later. Now, the reason it's listed in the pre-engraftment is people who are neutropenic pre-transplant. Remember, the depth and duration of neutropenia correlates with the risk of mold infections. So for like your leukemia or your MDS patients who had low counts before transplant, they never really recovered that well from their chemo, they may be higher risk to get Aspergillus. But people that come in with normal counts, and the pre-engraftment phase, they're more likely to get Candida, not Aspergillus, because you really don't get Aspergillus unless you are neutropenic and immunocompromised for a longer period and deeper period of time. But it can happen. What other kind of more quote-unquote supportive care kind of complications can happen in the pre-engraftment phase that are very common from these chemo agents?
Nausea, vomiting, diarrhea, and mucositis.
Yeah, so the GI effects are huge. Regardless of, I could almost put any of these regimens up there. You're going to have the same counseling points for patients. So nausea and vomiting can happen. Mucositis, those mouth sores from the chemotherapy can happen. And then diarrhea is pretty frequent from this type of high-intensity chemo as well. There's one other complication that can happen starting in the pre-engraftment phase, can also happen after that is really important to discuss. And I'll give you a hint, it happens at the end of the pre-engraftment phase.
Acute CVHD.
Good, acute graft-versus-host disease. You really can't get graft-versus-host disease without a graft. So they don't get graft-versus-host disease on day 2 of transplant, because the graft hasn't done anything yet. It's not even in the bone marrow doing anything yet. So really at the, what we call peri-engraftment phase, because sometimes we don't see the counts come back on the lab, but they're there in the body at low amounts. So you can get what's called hyperacute GVHD right before they engraft. It's actually a really, really bad prognostic factor, but it does happen. So acute GVHD can start in the pre-engraftment phase, but typically you don't really see it manifest in the body until the graft is there, because you need the graft to have GVHD. That makes sense, right? So those are the most common complications in the pre-engraftment phase. Going along that same line, group 1, since you've already started it, in the pre-engraftment phase, which is the first 30 days, what were the risk factors for the infections you told us? So you said HSV, Candida, potentially Aspergillus, and bacterial infections. So what is it happening to the patient that puts them at risk for those things?
The neutropenic.
Yeah, so neutropenia is obviously a risk of bacterial infections. What else is going on that puts them at risk for these infections?
Their normal gut flare.
Yeah, you whack them with all this chemotherapy. There's significant data and emerging data. Actually, they're doing like fecal stool samples and looking at exactly what bugs are in people's GI tracts pre and post transplant. There are huge changes in the normal flora, and that does put people at risk of different infections, not only of the gut, but systemically, because that mucositis is a barrier breakdown, right? So the bugs in your GI tract now get through into your bloodstream through the gut lining, so you can get infections of gut bugs in the bloodstream from that. And so that can be a risk, breakdown of mucosal barrier and destruction of normal flora. The destruction of normal flora also happens from the antimicrobial prophylaxis we use them, so that's an untoward effect. So what about the gram-positive bacterial infections they can get? There's another specific risk factor for that type of bug. Learn this in your febrile neutropenia session. It's one of the reasons you would give empiric vancomycin.
Is it the breakdown of mucosa or skin?
It can be, but specifically what skin, quote unquote, breakdown do all these patients have? For somebody in Augusta say it.
Like an access port or a PICC liner.
Right, they have a central IV access point to get all of these drugs we're giving them. So a central access device, if it looks infected, remember back to febrile neutropenia, is a reason to add broad gram-positive coverage, because gram-positives are skin bugs like MRSA. And so you need to cover that if they had their IV access device look bad, it was red, swollen, painful, pussy, whatever. Purulent, I guess is the official term, sorry. So those are the risk factors there. So let's go to group 25 and talk about the post-engraftment, so days 30 to 100. What are the risk factors for infection, and ergo what microbes are we worried about now? So their white count came back, but they still have risk factors for certain infections. What are they?
You say day 30 to 100 or past day 100?
30 to 100.
So we're worried about gram-positive CMV, Aspergillus, Candida, but depressed immune response with cellular and hemolymph.
Right. So post-transplant, at engraftment, we talked about engraftment is recovery of your neutrophils and then your hemoglobin and platelets after that. But your neutrophils aren't the extent, be-all, end-all of your immune system. You have T cells, B cells, and K cells, all these other cells that have to recover. And think back to your pediatrics. When kids are born, how long does it take them to have effective T and B cells? At almost a year, right? That's the normal progression of the maturation of your B cells and your T cells, and the fineness and blah, blah, blah. All that has to happen again for these patients. So it takes time, and you can Google graphs of different cell recoveries. So the neutrophils come back in 2 to 4 weeks. B cells and T cells take months, 9 to 12 months to fully reconstitute. So in this interim, they don't have as good of ability to fight off things like viral and fungal infections, because your white count is more for bacterial infections. You need the rest of your immune system to effectively fight off things like viruses, fungus, etc. So you can still have gram-positive infections, because a lot of patients still do have central lines, so they're getting electrolytes and blood products and all these other things. But because of that depressed humoral and cellular immunity, they are still at risk for viruses and fungus. And we typically see the CMV reactivation and the Aspergillus more commonly in this period. And then group 25, the late recovery, so after about day 100, patients may have risk factors for other bugs. What are those?
Sorry, we were muted. PCP, encapsulated bacteria, CMV, VZV, Aspergillus, and mold.
And specifically, what is their risk factor for the encapsulated bacteria?
Their functional asplenia?
Yes, if you have chronic GVHD, your spleen does not work. So if you're asplenic, this should make sense from kind of your general medicine knowledge, you're at risk of encapsulated bacteria, and ergo, then specific prophylaxis, which we'll get to in a minute. So these couple of slides about complications of when they occur, as well as the infection slides, are definitely very important, and it should make sense what time period they are. You know what their risk factors are. Based on those risk factors, you should easily be able to extrapolate what microbes are most common. That should kind of correlate with you. Now, we're only really going to talk about GVHD, VOD, and infection. There are a lot of other complications we don't have time for today, but I want you to be aware that the post-transplant complications can include effects on any organ, but we're going to focus on the most common and the ones that there's significant pharmacotherapy for. But these are highly testable slides, so if this was confusing for you, please talk to your neighbors and kind of make sure you have a good handle on it before the exam. So moving on, this patient receives tacrolimus per the GVHD prophylaxis roadmap. So group number 8, a new nurse asks you about the side effects, wants to know what to expect from this. What do you tell them?
The side effects can be that the drug is nephrotoxic, they can get hypertension, electrolyte wasting, specifically magnesium and potassium. So they're going to need a supplement, neurotoxicity, with the most common symptom being resting tremors.
pressure and electrolyte changes, and sometimes tremor and neurotoxicity are the most common things that we definitely want to monitor for and may need intervention. And as you said, there's some less common side effects that we don't have the time to really talk about today, but I felt like I needed to include them. But the high blood pressure, electrolyte changes, and tremors are kind of the specific effects we see very frequently in these patients. So the nurse also calls you back and says the TAC level is 22. What do you do first? It's not a trick question. It's the very first thing you do.
You probably hold the drug.
Okay. So before we decide to hold the drug because we're thinking it's super therapeutic, is there any logistical thing you want to consider? I don't think I talked about it in the pre-lecture for this, but think about what you learned in genetics about interpreting drug levels. Always
The timing of the lab?
good. So the timing of the lab would be important. So I'm just going to kind of tell you what we do in practice here, because I think always taking a step back before we react to something is get the whole picture. That's a clinical pearl. I always tell students on my rotation is someone calls you with a level or asks you a question, you never answer them. You always ask another question, because if you react too quickly, you can miss something. And that's how physicians work. That's not how we should work. So you get a level of 22, you want to find out how was it drawn. If this patient was taking pills and it wasn't drawn as a trough, it was drawn afterwards, that's not a relevant level and you wouldn't want to act on it, right? If it's drawn through the vein, one thing to know about tacrolimus and other drugs in its category is it sticks to plastic tubing. If you draw a TAC level from a line that's ever had TAC infused in it, typically within 2 weeks is what's recommended, you're going to get a falsely high result. Doesn't tell you anything. So they have to draw it from a different line or from a peripheral cyst. And that's something to always consider because people will react to a level and not look and see when it was drawn or how it was drawn. So you always want to ask those questions depending on whether your patient's on an oral or an IV regimen, because you don't want to falsely change a regimen based on incorrect data, right? So if this was drawn correctly, we know it's above the goal, and then yes, you may want to hold it or dose adjust. If it was drawn incorrectly, then we want to say, let's just recheck a level tomorrow accurately and then go from there. But don't react to things, always ask for more information. I wouldn't have you adjust doses on an exam. That's not something we talked about in the pre-class lecture. That's a little bit more of an art than a science. But I do want you to be aware what the goal range of tacro is and what the side effects are. That's the most important thing. And so if I tell you it was drawn from the line in which the TAC was infusing, what would you tell the nurse group 8? How would you kind of explain to them what to do?
That the levels are probably artificially high, that we need to get a new level.
And how do you want to instruct the nurse to get the new level?
Use a line that hasn't had tacrolimus going through it in the past week or get a peripheral.
Excellent, perfect. So the whole point here was just more about, don't react, always get more information. So let's move on and talk about the complications that occur after day 30. We will not talk about the infections because we just talked about that. So other than infectious complications, group 15, what would you list as some of the complications after day 30?
Infection, graft failure, and acute GVHD.
Right, so after day 30, if they haven't been grafted, we'd consider that typically graft failure. It's not common, but it can happen. As we talked about, there are infectious complications. Chronic graft versus host disease can occur later on, as more typically as well. And then the other thing is disease relapse. So transplants aren't 100% effective. Some patients will have their primary malignancy come back despite the graft. Unfortunately, some patients can have graft versus host disease and relapse at the same time, and that is a very bad thing. So that would be the worst case scenario. Before we move on to the next part of this case, I took out a piece of the case for the sake of time, but I want to reiterate a few key points here for you all. That's infection prophylaxis. So overall, for the purpose of examination, all auto and allo patients are going to get a fluoroquinolone prophylaxis to prevent bacterial infections. I want you to be aware some hospitals don't do that based on their antibiogram and other local susceptibility risks, but in general, Antibacterial prophylaxis is recommended in the pre-engraftment phase to reduce the risk of febrile neutropenia. So all of our patients, for the sake of the exam, are going to get that. Patients with chronic graft versus host disease, we talked about they're functionally asplenic, so they're at risk of specific bacteria. That can be covered with penicillin prophylaxis. So if you have chronic GVHD, you should be on penicillin as prophylaxis for encapsulated bacteria. Otherwise, nobody else gets the penicillin. It's only for people with chronic GVHD. Other prophylaxis that's required post-transplant is viral prophylaxis. So all patients get acyclovir. Some hospitals do valacyclovir, valganciclovir, that's fine, we're not going to talk about that. For the purpose of us, it's acyclovir, and that's to prevent reactivation of HSV, which almost everyone has been exposed to, and VZV, which again can be the shingles reactivation. So patients will get acyclovir. You don't need to worry about the dose. Any dose I put on the exam would be correct, so don't worry about that. But all patients are going to get acyclovir prophylaxis. If you're an allogeneic patient and you're at risk to reactivate CSV, you're probably going to get letermovir. So for the purpose of the exam, we're going to say you will get it. That's only for allos, and it's only if they're at risk of CMV, so they were CMV positive. Ganciclovir is only used to treat CMV reactivation. I'm not going to test you on ganciclovir. I'm just commenting because I want you to be aware of it, that is the drug that we use to treat CMV reactivation in an allogeneic setting. Auto patients aren't at risk for CMV reactivation because, again, there's no immunocompromised state. They're getting their own cells back, so we don't have to worry about it. All patients post-transplant get an antifungal. For the purpose of the exam, we're using fluconazole. I understand in practice people are doing different azoles, but again, to streamline it, we are going to say fluconazole. So if you're an auto or an allo, you get fluconazole until you're not neutropenic, and if you're an allo, you're off immunosuppression. And then allo patients also need PJP prophylaxis. We typically don't start that until they engraft, and that's because Bactrim causes myelosuppression. So you wouldn't want to give them the side effect that's going to delay their engraftment. Plus, PJP grows really slowly, so the chance of actually having PJP in the first 14 to 30 days is pretty low. So you can skip prophylaxis until they engraft and then start it. That would be totally fine. So allos need a lot more prophylaxis than autos, right? Autos get a bacterial, fungal, viral. Allos also add on letermovir if they're CMV positive, PJP prophylaxis, and penicillin if they end up with chronic GVHD. So who gets which one is the important point here. Okay, so now our patient, AJ is day 35, has nausea, diarrhea of less than a liter, abdominal pain, and a rash on about 20% of his body. I give you some workup. So group number 20, what would you say this patient is being diagnosed with?
Acute GVHD.
Good. So acute GVHD based on their diarrhea and skin rash. So I won't have you stage and grade on an exam. You can always look that up, and it should be documented in the medical record by the physician. But I wanted you to be aware that there is a staging and grading for this based on the volume of diarrhea, the percent of the skin rash, and the T-Billy level if they have hepatic involvement. So the patient is on 1 milligram twice a day of Tacro, and the level was 9. Given the diagnosis of acute GVHD, what's the goal TAC level, and should we do anything with their pharmacotherapy group 20?
The goal level is 5 to 15, and you should add methylprednisolone 2 mg per kg per day.
Exactly. So the treatment of graft versus host disease is corticosteroids. 2 milligrams per kilogram per day is the starting dose. What happens after that, we're not going to talk about because it gets kind of complicated with a lot of clinical controversies. But steroids, 2 mg per kg per day, is the appropriate initial treatment for graft versus host disease. And this is because graft versus host disease, remember, you got donor graft, is identifying the patient's body as foreign and fighting it off. So you need to turn down the immune system. One of the most broadly used immunosuppressive agents are corticosteroids, right? So it's going to turn down through a variety of different mechanisms the immune system to kind of quiet that graft versus host disease. We also will continue their calcineurin inhibitor. We don't stop the Tacro at this point. We add on the corticosteroid. Now, if they weren't optimized on their TACRO goal level, let's say the level was 2 or 3, you would optimize the TACRO and add the steroids. That would be appropriate. And obviously, if their TACRO was high, you back off on it because you don't want to be super therapeutic. There's no benefit beyond a certain level. But we would add on steroids in the case of GVHD. So what are some risk factors to GVHD for this patient and just in general? Same group.
The HLA disparity, mismatch, older age of donor or host, conditioning regimen, higher risk with myeloablative regimen, gender mismatch, CMV infection, and the number of CD34 cells that are reinfused.
Right, so the two that make the most sense kind of off the top of our head is the HLA disparity. We talked about that under the physiology section, right? If you're more mismatched, you're more likely to have recognition of self versus non-self, and therefore you're more likely to have GVHD. More number of CD34 cells infused is more of the immune system coming in all at once, so that should also make sense. And some of the other ones are based on risk of immunogenicity. So we talked about cord blood having a low risk because it hasn't been exposed to anything. But older patients and donors have been exposed to a lot more things. So their immune system is much more competent and much more reactive. Myeloablative regimen primes the body to have inflammation, and inflammation turns on the immune system, so that's the reason there. And then CMV and gender mismatch are ones that have been correlated in epidemiology studies based on patients, again, being a little bit more primed to look for things. Their immune system is a little bit more turned on and ready to go. So Paris females, their body has already been exposed to another person, quite literally, and they had to come up with some immunocompetence to carry the fetus. And so their immune system just has a little bit more recognition of things, and therefore they can cause a little bit more GVHD versus male patients. The male patients has the lowest because they've never been pregnant, which obviously makes sense. Good. So our last case is a KM, who's a 55-year-old female with myelodysplastic syndrome, which is a condition fairly antecedent to acute leukemia. The patient's baseline weight is 85 kilos. She's received a matched unrelated donor. She got fludarabine and busulfan for conditioning, and she's on tacrolimus and had received APG and methotrexate for prophylaxis of GVHD. On day 8 after the transplant, the patient appears jaundiced. Their ins and outs are 3.2 liters over 1.7 liters. Their weight is up to 89 kilos. They complain of painful hepatomegaly, and other labs are all pending. So as soon as you see this, the first complication that kind of pops into your head, group number 13 is what?
What question?
It's number 1, right? SOS.
Right, so based on the painful hepatomegaly, weight gain, and if I gave you a T-Billy that was high, that would also be a component of the criteria. This is VOD. So I didn't give you all the labs yet, but I wanted obviously to see that the signs and symptoms typically present pretty clearly. And it typically occurs in the first 30 days, after 30 days, after 100 days. Does this patient meet the typical course or no?
Sorry, can you ask that again? I didn't really understand what you were asking.
So this, like the time frame of diagnosis. So if we say this patient has SOS, does this patient fit the typical picture of when SOS is usually diagnosed or not?
I would say yes, it's because it's usually within 20 days if they're at day +8.
Exactly. So it's usually within the first 3 weeks of transplant. On the graph, it's usually charted in the first 30 days just because they like to have nice even numbers of 30 and 100. But technically, the first 3 weeks is when SOS usually occurs. So based on their presenting signs and symptoms and timeline, we would clearly be able to say this patient is on a clinical diagnosis, has SOS, or formerly called VOD. So what was this patient's specific risk factors for this complication? Same group.
She had an allogeneic transplant and she had the busulfan, which is a hepatotoxic agent.
Good. There's one more risk factor. So methotrexate also can cause some hepatotoxicity. And so receiving the methotrexate as part of the prophylaxis would increase the risk. That's another drug induced because that drug, as we talked about before, can cause renal and hepatic toxicity. So that would also be a risk factor. Okay. So group, let's do 19. What should the patient have received to prevent SOS? What is the prophylaxis that's recommended?
Ursodiol 300 milligrams POVID, or you can do 12 milligrams per kilogram per day divided.
Yeah, so ursodiol is the bile acid sequestrant that kind of helps keep things flowing through the liver to prevent VOD. Because remembering that the pathophysiology is fairly complex, but basically injury in the liver causes inflammation and coagulation, and that can cause narrowing of those tiny little vessels, and then backflow of all of the blood that's going through the liver normally to be filtered. It kind of backs up, and that's what leads to the hepatorenal organ failure and then potentially death. So if we can keep things flowing through those tiny little sinusoids as best as possible, that is necessary. I put on the slide that some institutions historically have used anticoagulants to kind of also keep things flowing, but obviously in the post-transplant period where their myelosuppressed, they have low counts, anticoagulation can increase your risk of bleeding. So risk to benefit, most institutions don't do that because you get more bleeding and more bruising, and there really hasn't been enough data to show that that actually works. So even though VOD is a procoagulant problem, anticoagulants haven't been shown to really make a benefit in the prevention of it. So ursodiol is the only currently recommended gold standard for prophylaxis. So for intervening at this point, let's say this patient was on ursodiol, but they still got VOD anyway. What are the recommended interventions as well as monitoring necessary? Same group.
Blood pressure, and make sure. And we would treat with defibrotide, the dose hours for 14 to 21 days.
Good. So the treatment of VOD is to continue their prophylaxis with the ursodiol and add on your defibrotide. And I agree with you, the defibrotide is typically started as soon as you're diagnosing a patient clinically. There's data to show that earlier intervention improves outcomes, despite overall fairly low data with that drug to begin with. So we would need to start defibrotide as soon as we diagnose someone with VOD. I agree that diuresis is the most important supportive care, but there's a couple other monitoring things when you look at the signs and symptoms of VOD and you want to give diuresis. What are some kind of relevant monitoring parameters thinking along that line? Would you add to your list?
Urine output, potentially potassium.
Yeah, so strict ins and outs are vitally important when you're trying to prevent and manage VOD. So we make our patients get up and stand on a scale every day, sometimes even twice a day, and we dictate how much diuresis they're going to get and how many IV fluids they're going to get based on their daily standing weight as well as their ins and outs. And so we don't obviously want people to be hypovolemic or an AKI or anything, but we try to keep them as euvolemic as possible because that's been proven to prevent and help manage VOD. So they have daily standing weights and strict ins and outs, and so we would titrate their fluid as well as their diuretics accordingly. I agree with you, if they're going to get diuretics, some electrolyte monitoring is probably necessary to make sure they're not having side effects of those interventions. And if they have VOD, monitoring for the organ complications like watching their creatinine, as well as their respiratory status to look for those organ failures is a relevant comment. But the ins and outs and the standing weight are the most important things because keeping them euvolemic is very important. Of course, we're going to trend their bilirubin and their if they had any symptoms of ascites or
hepatomegaly or pain, we would continue to monitor those things, but you don't necessarily do anything about those things other than the diuretics for the weight and the ascites, of course. So prophylaxis, ursodiol, treatment, defibrotide. The other thing about defibrotide to be very aware of is if your patient is actively bleeding, you are not allowed to give defibrotide. It's an antithrombotic and antifibrinolytic therapy. So based on its mechanism, it should make complete sense that you don't give it to people who are bleeding. You are going to make their bleeding worse and they could literally hemorrhage and die. So you don't give this to people with an active bleed. Otherwise, it started promptly for patients with a diagnosis of VOD. Technically, you can diagnose VOD with a biopsy, but sticking a needle into their liver in the post-transplant period is not a good idea, right? Think about it. Post-transplant, they have low blood counts. There's thrombocytopenic and anemic. Your liver is a giant sack of blood. Are we going to stick a needle into that? Probably not. So we typically don't actually do a biopsy for liver GVHD or VOD. We go based on clinical signs and symptoms because it would be too much of a risk for not enough of a benefit. We can diagnose VOD more on ultrasound and things like that. We typically don't actually get a biopsy for it. So you wouldn't be able to see a specific result, in the chart for that. Other than maybe you were showing the kind of reversible portal flow on an ultrasound or something, you could see those non-specific findings, but this is diagnosed based on the signs and symptoms. So remember, the signs and symptoms are, weight gain, your high T-billy, ascites or hepatomegaly. I included the charts of kind of what the criteria are, exactly what the cutoffs are. I would never test you on, but if you had a patient with hyperbilirubinemia, hepatomegaly, ascites, and weight gain, that should trigger you to think VOD, right? You don't have to know the exact cutoffs, but the constellation of symptoms should make sense. Versus somebody who presents with diarrhea, rash, and hyperbilirubinemia, that's probably acute GVHD, right? So based on their signs and symptoms, you should know what interventions to make, but I won't trip you up on are they mild, moderate, what the cutoff is, anything like that. It'll be a little bit more basic than that, just so that I know you know what the intervention should be and what the supportive care should be for these various complications. Any questions on VOD? Yes, ma'am. That's fine.
So do you discontinue the fluoroquinolone graft, or does that?
That's a very good question. So fluoroquinolone prophylaxis for autos and allos continues until engraftment or onset of febrile neutropenia, which is much more likely in your allo setting. So as soon as someone has febrile neutropenia, they don't need to be on their prophylaxis. You're going to start your normal Cepheine, Zosyn, plus minus vancomycin kind of strategy. But if they don't ever have febrile neutropenia, then once they engraft, they come off of their fluoroquinolone.
And if that was an allo patient and then they end up developing chronic GVHD, that's when you would add the penicillin?
Yes.
And
so
would you take that off once that resolved?
So once their chronic GVHD resolves, you technically could. Chronic GVHD is not that easy to manage. So in my experience, I've not had people who didn't either continue to have GVHD or die. So I've never taken anybody off. It can happen, I guess, but unfortunately, chronic GVHD is a chronic problem. We can manage it, we can mitigate it, but very few patients completely come off whatever immunosuppressive therapy they end up getting on for chronic GVHD. Now, a lot of chronic GVHD management is supportive care and topical things. So if you have oral or vaginal or whatever their topical treatments for that, sometimes they're on systemic therapies, yes, but there are a lot of topical things that we do, and they stay on those kind of chronically. Chronic GVHD is unfortunately quite common in people who have had acute GVHD, and chronic GVHD typically is in more than one organ in patients, and like one organ will get better and then another will get worse, or another will crop up. So it can be very difficult to manage because it's not as simple as you have this one organ, here's your treatment, you either get better or you don't, you start second line therapy. It's a constellation. Typically, most patients, they present with multiple things, and some get better, some get worse, some resolve, something new crops up. It can be just difficult to manage overall. There are grading and scoring criteria that are multiple pages long that they have to assess the patient in. And those patients can typically have significant morbidity. Chronic GVHD typically doesn't kill a patient, but there's a lot of morbidity to it, a lot of decrease in quality of life that happens from the various symptoms that they can have.
For example, oral GVHD, which is fairly common chronically, causes very dry mouth. That doesn't sound like a big deal, but if you think about it, if you have chronic dry mouth, what happens? It's very difficult to eat, right? You can have dental caries, which doesn't sound like a big deal, but in patients who are immunocompromised, dental caries and having dental work means what? Infection risk, right? And then your infection can progress to endocarditis. And it seems literally snowball really fast. With these patients, one small thing turns into 2 or 3 major things very quickly. So things that seem small, like dry eye. Chronic dry eye can make these patients go blind. I have had patients go legally blind from chronic GVHD of the eye. So things that don't sound like a big deal, unfortunately, really can progress in some patients despite optimal therapy and doing the best we can into things that cause significant morbidity. So it sounds bad to say it, but acute GVHD can kill you. Chronic GVHD just makes you think you want to be dead. Like that's unfortunately how this pathophysiology works in the time frame that it works. We're making strides to help prevent it and manage it, but there's a lot of research going on in various different immunosuppressive regimens and combinations to try to prevent and manage these complications. But graft versus host disease is definitely the most common and important thing we have to counsel patients on so they know what the risk is acutely as well as chronically from the issue of the incompatibility of the stem cells in the body that right now we just don't know enough about how to perfect and prevent it. What other questions can I answer? Okay, well, we'll just be done a smidge early today. If you think of anything, please email me. And we have one more session on Monday for solid organ transplantation, and then the exam, I believe, is next Friday. Thank you.